Hi, and welcome to this webinar. This is Dr. Rick Ferguson. Before I get started, I would like to thank OsteoNews for hosting this webinar, and a little bit about myself. I am a clinical assistant professor at the University of Florida. I'm a director at a company called Implant Educators, and I'm in private practice in Davie, Florida. Before I get started, I do want to mention my disclosures. Although I am not getting any financial support for this webinar from any commercial interest, I do lecture from time to time for and get support from companies, BioHorizons Implant Company, Prexion, which company that makes cone beam CT scanners, and Salvin Dental. So with that out of the way, I want to get started with the webinar. The topic today is extraction socket grafting, the backbone of the modern dental implant practice. I mentioned that I do run a company called Implant Educators. We run a 7-month training program in Florida, along with my co-directors, Dr. Arthur Acker and Dr. Catherine Ferguson, who is also my wife. We run this program in collaboration with the University of Florida College of Dentistry, a Department of Continuing Education. The program is a comprehensive interdisciplinary program teaching dentists and specialists how to become implantologists, and we cover a full spectrum of implant dentistry. Here are some cases, for example, that our students have done grafting procedures in our course. We teach grafting procedures as well as implant placement, guided surgery. And it's sort of a unique program because we can bring doctors from anywhere in the United States, any licensed practitioner, and they can actually treat patients in our program. I know there are programs available now in South America and in the Caribbean. We do a similar thing, but you don't have to go out of the country. One of the things that we try to do in our course is that we use 3-dimensional imaging for all of our dental implant planning and implant treatment. In 2012, the American Association of Oral Maxillofacial Radiologists had a position paper that 3-dimensional imaging should be used for all dental implant planning. And here we are at our course. This is our conference room. We're going over the case for that day, or one of the cases we're going to be doing surgery on. So we treatment plan all the cases, and we review them that morning. The students actually treatment plan the cases with us, and here we are doing surgery. Dr. Acker and myself, we have cone beam scanners. This is a Prexion scanner, which I have in my practice. And in our program, we teach implant dentistry as it should be practiced in a private practice setting. So all of the cases are treatment planned using cone beam CT. The cases developed and executed with this imaging modality as our background, as for our cases. So that's a little bit about me and what I do. I've been practicing implant dentistry now for about 20 years, and we've developed our comprehensive training course over many years of sort of trial and error with different programs, teaching with different programs. And what we've developed is sort of a unique situation where doctors can actually come in and learn implant dentistry over a course of 7 months with various specialists and in different aspects of implant and dentistry. And they can go ahead and actually do some of the surgical procedures and learn some of the bone grafting procedures on real patients. But the crux of what I would like to talk about today is the socket graft. The socket graft, to me, is the backbone of implant dentistry, of the implant dental practice. And what I want to talk about is how to prevent a case like this, which you see on the screen. In this situation, an implant was placed without adequate bony support, with probably not enough soft tissue support as well. But we'd like to certainly prevent this type of a situation. So let's move on, and we'll talk about how we prevent this. Now, the case I just showed you was probably done without proper bony support. So how much bone do we need around implants for long-term stability and aesthetics? Well, if we look at a rule of having 2 millimeters of bone facial to the implant and palatal or lingual to the implant, and let's say in the anterior zone we're placing a 4 millimeter implant, and we have 2 millimeters facial, 2 millimeters buccal, that comes out to be about 8 millimeters. If we give ourselves another 2 millimeters of leeway, we see that we need approximately 10 millimeters of bone in the anterior, and in the posterior we're typically placing wider implants, let's say a 5 millimeter diameter implant. We come out to about 11 millimeters of bone. And a lot of times we don't have that much bone. So the problem that really happens is we take out teeth, but nothing is done with the extraction site. So we lose bone. And what I'd like to really stress today is how we can prevent some of this bone loss and maybe even gain bone and soft tissue by doing a socket grafting procedure that is predictable and that will give us a site that is developed for an implant. We know that we lose bone and that bone loss will continue over the patient's life, so it's important that we do this right away. And I'd like to illustrate the consequences of not doing a socket graft or not doing bone grafting at the time of extraction. This patient that you see on the screen is Dawn. Dawn's in her early 40s. She has a tooth number 31 that we deemed unrestorable, and we were going to extract the tooth. And we treatment planned Dawn for an implant placement there with a socket graft, and then go back in 4 months and place an implant. But Dawn was also having some TMJ problems. So before we went ahead and did that procedure, she had some treatment done by an oral maxillofacial surgeon. She had actually TMJ surgery. And we knew she was going to have this done, so we told Dawn when she's finished with her TMJ treatment and her surgery, she can come back and we'll take out that tooth number 31, and we'll go ahead and do a socket graft. And we developed a treatment plan for socket graft with future implant placement in about 4 months, and then a final restoration with an abutment and crown. The problem arose in that when Dawn went and had her TMJ surgery done, the surgeon decided to extract number 31 at the same time, thinking that he was going to do her a favor almost and just have one surgical procedure. However, no socket grafting or no site preservation was done, and this is what Dawn looked like 5 months later when she came back after having her TMJ surgery. Now, her TMJ surgery went very well. As a matter of fact, she was completely pain-free after the surgical treatment, and after her healing, she was able to restore her function. So that aspect of it went really well, and she presented about 5 months after the extraction, after our initial consultation, and said, okay, I'm ready to have my implant done. The problem was that now we had lost a lot of bone because no site preservation was done. And I assumed that the tooth probably wasn't taken out atraumatically as well, and I'll discuss that in a few minutes. But we looked at the site and said, well, I don't think we have enough bone, and we went ahead and got a CT scan and realized that we did not have enough bone to place an implant, so we had to change our plan. So instead of doing a socket graft, now we did a tenting procedure using tenting screws and membranes, and it was successful. We were able to grow the bone, as you can see in this before and after. The left side is the before and after, is on the right side, how we were able to build a bone facially or buccally enough so that we could place our implant. So we were able to restore the contour of the bone there, and we had adequate height. We just needed the width. And again, here's a three-dimensional view of that as well, how we were able to build out the bone here. This is, again, the after on the right-hand side. And so our procedure was successful. And we went ahead, and after the bone integrated, we were able to place our implant, and we were able to restore the site with an abutment, custom abutment, and a crown. The problem here is that instead of the grafting procedure or socket graft at the time of extraction, which was going to run her about $600, it became a $2,500 bone graft procedure in order to restore the site. So this could have been avoided by doing a socket preservation procedure at the time of implant placement. It's important that we keep in mind that we have to preserve as many of the bony walls of the socket as possible when we take out teeth. This allows regeneration of bone for future restoration and implant placement. So I'm going to talk a little bit now about atraumatic extraction. There are many ways to take out teeth, but to me the keys to atraumatic extraction begin with section and multi-rooted teeth using instruments such as piezotomes, thin-bladed elevators, obtaining maximum mobility prior to the use of forceps, and vertically removing the roots using forceps. One of my favorite instruments is the Impact Air 45 handpiece, which we use to section teeth. This is a handpiece that is very easy to adapt to a general practice, for example. It does not blow air out of the front of the handpiece. The air is exhausted through the back, so there is a reduced risk of air embolism. You can use a surgical length. It has a 45-degree angle to the head, from the shaft to the head, so it allows you access, for example, in the posterior regions. So that's what we use to section teeth. We also use periotomes, and then my favorite instrument to use is the piezotome. The piezotome allows you to literally work your way down the PDL space, and at this point, once you're down there, the teeth will literally just fall out. So we use it, for example, in this case, to work our way down into the PDL to loosen the tooth up, especially with teeth that are ankylosed. This is a very useful tool. Now you see in this slide I'm using it on the facial bone. If the facial bone is thick enough as it is here, then it's fine to use there, but a lot of times the facial bone is very thin. It could be as thin as a 1/4 millimeter or sometimes non-existent. So you have to be really careful with this instrument, and you don't want to use it where there's very thin bone. Most of the time we're using it mesial and distal, where the bone is thicker between the roots of the teeth, and then we can take the tooth out once we've loosened it up using the piezotome, working our way down into the PDL space. So here's a case. This is Lucy. Lucy has a couple of teeth that needed to be extracted. We decided to extract the molar because of the angulation issues, and then the premolar here you can see has a decay on it, previous root canal treatment, and we decided to extract both teeth, put in 2 implants, and make a 3-unit bridge. So you can see here we're using the piezotome to work our way down into the PDL space on the mesial of the tooth, and we switch to the distal. And these are still slides, so you don't see the spray of saline that comes out of and cools the tip of the piezotome at the same time. But it's a really neat instrument, and you get a clear view of what you're doing, and you're able to work that tip right down into the PDL space, circumferentially around the tooth, and you can see it goes pretty far down. One of the things with the piezotome that you have to be careful with, though, is as you're working, keep the tip in motion, because that tip will heat up, and you have to keep it in motion, keep the saline coolant spray on it at all times. But if you keep that in mind, keep that tip in motion, it's a very effective tool. And then at this point, once we've worked our way and separated the tooth from the bone, we're able to just elevate it out and remove it, and then we can do our socket graft or socket preservation technique. And here you can see the site is sutured after we've extracted the teeth. Here's another case. This is Will. Now Will has a tooth that, again, needs to be removed. We can see that there's a large decay on the mesial aspect of the tooth. So one of the first things I'll typically do is go ahead and section the tooth and get the distal root out. And here I'm using the Impact Air handpiece with a Fisher burr. This is a 702 Fisher burr to section the tooth, get that distal root elevated and removed. We can remove it with forceps, and there it is. You can see how we're able to section very accurately, precisely down the middle of the tooth. And then we can, if we can elevate out the root, the remaining roots. Here I was able to elevate out the mesiolingual root. But the problem was now the mesiobuccal root was ankylosed. So as you can see, we started elevating it. It fractured several times. It was very brittle. So that's when now we incorporate our pisotome. We took our pisotome, with our LC1 tip, worked it down into the PDL space, and because of the vibrations, this root tip actually just sort of popped up out of there because of the vibratory motion of the pisotome tip as it went in. So very effective because of the angulations, and these tips come in various angulations. You're able to get into spaces that you couldn't get into with a handpiece, and it's a very thin-bladed instrument, so you preserve as much bone as possible. And here's the root that we got out of there. It just sort of popped out as soon as we put that pisotome down in there. And here is our socket now. We've preserved our bony walls in all sides, and we can do our socket graft. We put our bone graft in, put our membrane over top, and just a figure-8 suture closed over there. And the bottom line is atraumatic extraction is going to take more time. But there are benefits to the patient, as we saw with Dawn's case. If we had taken out the tooth number 31 atraumatically, it would have benefited the patient tremendously and not have to do a more advanced bone grafting procedure later on. The problem, though, is that atraumatic extraction does take more time, but we don't get paid more to do it. So let's see how we can change that. Learn socket grafting and implant placement. Let's look at the economics of grafting and implants in our practices. As in Dawn's case, there's always a moral to the story. You can pay later or pay now, and we know that paying later is always more expensive. If we had taken out the tooth and done a socket graft, it would have been less costly for her, and frankly, she wouldn't have had to endure as many procedures as well. So we have a choice. We can graft a socket or not graft a socket. We know that not grafting a socket is going to cost a patient more later on. So if we choose to graft a socket and we charge, let's say, a reasonable fee, might be $600. I made this slide several years ago. My fee to do this procedure has actually gone up since then, but let's just say this is a reasonable fee to do extraction socket grafting, not including the extraction. That's just to do the grafting procedure, and it takes about 10 to 15 minutes, and we know it's very predictable. Compare that to not doing the socket graft, losing the bone volume, and having to do a $2,500 procedure later. Patients are not going to be very happy about that, and if you explain it to them in these terms, a lot of times they'll accept the treatment. The other thing about it is if we look at your typical practice, the alternative is to not do anything, or another alternative would be to do an immediate placement of an implant into that socket. Well, a lot of times we don't have enough time in our schedule because we see these patients that need these extractions on an emergency basis. So a lot of times we don't have the half an hour or the hour it's going to take to set up and do an implant procedure. But we do have time to do a socket graft. We can usually find 10 or 15 minutes to do a socket graft. And in our practice, if I tell my assistant we're going to be doing a socket graft, in about 5 minutes she can have a room ready to go to do that socket graft, in addition to the extraction. So it's something that can easily be incorporated into most practices at a very minimal cost. That's going to benefit the patient tremendously and frankly benefit the bottom line of the practice as well. So let's look at the numbers some more. If you graft half of all your extractions, we're not saying you're going to graft every single extraction you do, not including wisdom teeth. At half of all your extractions, you extract 4 teeth per week at $600. The socket grafts are going to be about $600. So you're going to do maybe 2 per week, except a socket graft. That's $1,200 per week you're going to add to your production. If you take 2 weeks off per year, 50 weeks of work, that's $60,000 per year added to your production. Not too bad. So let's say half of those sockets that you grafted, meaning only a quarter of all the extractions, have an implant placed in an extraction site. Start to finish for a single tooth implant, a low fee today is about $3,000. And you had 4 extractions, 2 accepted the graft, 1 accepted the implants. That's about $3,000 per week. Again, you know, look at your 50 weeks of work. So you're looking at about $150,000 added to your production from the implant cases you're going to be able to get from doing this socket grafting procedure. And the nice thing about the socket grafting procedure is when you go back to put those implants in, those sites are going to be pristine. You will have grown bone and soft tissue using the technique I'm going to talk about in a few minutes here. Those cases will be pretty much slam dunk cases. You'll know, first of all, you will have been into that site before you took the tooth out. You will have grown the bone to fill in that site. You will have grown soft tissue as well, keratinized tissue, if you use the Cytoplast technique, which I'm going to talk about. Those become pretty straightforward cases. So now instead of implant dentistry being a stressful procedure, it becomes an enjoyable procedure. So we're looking at $60,000 added to our production per year in socket grafting and about $150,000 in the implant cases you're going to generate from your socket grafting. That's about excuse me here for a second. That's about $210,000 added to your production from adding socket grafting and simple implant placement to your practice. So again, going back to why we're doing this, it's certainly for the patient's benefit. And in our practice, when we do these procedures, it's like clockwork. Our implant practice stays busy because we know when we do a socket graft, in 4 months we're going to be placing, sometimes less depending on the case, but in 4 months we're going to be placing that implant. So everybody in our practice knows the sequence. We take out a tooth, we do a socket graft, in about 4 months we're going to be placing that implant. And it's like clockwork, so it keeps your practice busy as well. So let's look at the conditions necessary for utilizing grafts, because it's important to understand our bone grafting procedures and how these work. First of all, we're going to need a site free of infection. We're going to need a source of osteoprogenitor cells, which in this case of socket grafting is going to be from the bony walls of the socket. That's why it's so important to do a traumatic extraction. And we're going to need to exclude epithelium from that site to allow our bone graft to regenerate into the patient's native bone. As far as the bone graft material we're going to use, we want it to be replaced by dense functional bone in a prescribed time, and I'll elucidate on that more later on. We want it to be subject to normal bone remodeling. We want it to basically turn over into the patient's own bone so that we can place an implant and have long-term stability of that implant. Of course, we don't want any donor site morbidity. We don't want it to migrate. We don't want to transmit any diseases with our bone graft material. We don't want our patients to reject it, and we want it to be a relatively low cost so that patients will accept the treatment. And if we look at the available bone graft materials that we have today, we have autografts, allografts, xenografts, and Allografts. And it's interesting to me that allografts are the material seems to be of choice these days for socket grafting and a lot of other procedures as well. 20 years ago when I started in implant dentistry, allografts were also the most common material to use in bone grafts. And it's sort of the material that has stood the test of time. As you can see, if you look at most of the major implant companies now, they also carry their own brand of allograft material. So allograft is the material of choice. This is what we're going to use for our socket graft. Allografts regenerate bone through osteoconduction, which is where the grafts basically provides a scaffold that is compatible with bone healing and that allows revascularization and repopulation with osteoprogenitor cells from the native bone, the socket walls in this situation. And we have various examples of different types of graft that that provide osteoconduction, but again here we're just going to be talking about allografts. And I like to use mineralized allografts. I think looking at the study in 1994 from Shaneman, we see that predictability of guided bone regeneration procedures seems to increase with the amount of mineralization of the graft. So I use mineralized allografts for my socket graft. And we're going to be using a material that's going to turn over in about 2 to 6 months. In our comprehensive course, I do teach other materials that we can use in sites, or if we want to stretch it out to a year or greater than a year, excuse me, or never. If we never want to place an implant into a site, there are materials available, but that's not going to be covered today in this webinar. So we want new bone to form. We want that is similar to the pre-existing bone. We want to have a good quality and quantity of bone, and we want, even after implant loading, that this bone should be of a good quality and able to integrate our implants. And if we look at this case where we took out a tooth and placed this allograft, this is a Mineralized product from BioHorizons. This is a mineralized allograft. At 2 months, we're able to regenerate the bone. It's a small socket, so it's not unusual that at 2 months we should have bone filling into the site. At 2 months, we're able to go back in and place an implant. So what we're trying to do is basically prevent what you see up here on the top and have a situation like we have on the bottom through our grafting procedure, our socket grafting, so we can place an implant. The steps involved in doing the socket graft are fairly simple. We're going to atraumatically take the tooth out, debride the socket, curette the socket to promote marrow healing and clot formation. We're going to introduce our bone graft and our barrier material, suture the site, and we always put the patient on antibiotics because there is no vascularity to this graft that we've placed, so we do need to put the patient on antibiotics. If the site is infected, and when I say infected, I mean really truly infected, that you know the tooth is a hot tooth. That's a term we seem to use in dentistry to describe a site that doesn't respond well to anesthetic, that has purulent discharge coming from it, where it's truly infected. A lot of times we'll take out the tooth. We still want to take the tooth out right away. As long as you leave that tooth in there, you'll continue to lose bone around it. Debride the socket, but we want to put the patient on an antibiotic for 1 or 2 weeks till that the site has calmed down. Then we can go back in and do our socket graft as before, curetting the socket, introducing our bone graft, and suturing and our barrier suturing and prescribing antibiotics. So let's look at this allograft that we're going to use for a minute. The particle size that I think works the best is 600 to 1250 microns, and it comes in a variety of sizes. The one I would recommend is ½ cc. For most sockets, this is what we're going to use, and it's very unusual to use 1 cc for a single tooth socket. Of course, if we're doing multiple teeth next to each other, we might need to use 1 or more cc's. But this material is constituted with cortical and cancellous chips, and there's a reason why we like to have both. The cortical provides a dense structure to the bone graft and provides space maintenance and function. It also serves as a radiographic marker, whereas the cancellous portion has increased surface area to allow osteoprogenitor cells to deposit, and it gives us our osteoconductive scaffold, and also allows porosity for revascularization of the site. We do use this material for other clinical applications such as ridge and sinus augmentation and bone augmentation around implant, and most bony defects we will use this material as well. So now that you have the graft in place, let's make sure it stays there and that nothing grows in to interfere with it. It's important that it not migrate. That was one of the things that we had on our list before. And that's why we use a membrane. We're going to prevent particle loss, but we also want to prevent epithelial migration into the socket. And I know there's some speakers that talk about getting primary closure over the site or using collagen membranes, and I'll address those here at this time. I don't like to get primary closure of my site because it means changing the gingival architecture of the site. So we will use a membrane that is non-resorbable that will hold the site open so that we can get granulation of tissue over the site. And that brings us to our barriers. Like I said, there are resorbable, non-resorbable membranes. The most common resorbable membrane is collagen. The one that we use, the non-resorbable membrane we use is a Cytoplast membrane, and that's a technique that we use for our socket graft. If we look at the collagen membranes are wonderful for regenerating bone and guided bone regeneration procedures, but they're not designed to be exposed to the oral environment. As a matter of fact, none of the materials here are really designed to be left exposed to the oral environment, and they break down rapidly. So if you look at a situation like this is a case that I did when I was using collagen membranes. You can see here at 2 weeks, we've got complete loss of the collagen membrane. It's broken down completely, and we can see our bone particles exposed. Whereas when we use a non-resorbable membrane, 2 months, we've got basically a regenerated site, and we don't need to have primary closure over the site because we're using a non-resorbable membrane. And then here you can see this bone that we're able to regenerate. We can drill our osteotomy, and then we can go ahead and place our implant. And you can see the implant is of a good size. We have bone on both sides of the implant, and we'll have a successful implant placement there. So this is a technique that I use in my practice. This is the one we teach at our course. We teach other techniques as well, but as far as the most predictable technique that we can teach people and the one that we use on a regular basis in our practice, it's called a Cytoplast technique. It was developed by Barry Bartee. And I said it was predictable. And we have a saying at Implant Educators: if it's predictable, it's profitable. Predictability equals profitability. So it's something that's, again, easy to incorporate into most practices, and it makes implant dentistry very predictable. And again, if it's predictable, it can be profitable. There's a minimal amount of instrumentation that goes into this technique. You'll need some sutures, you'll need needle holders, a good periosteal elevator, scissors, tissue pickups, your membrane, and your bone graft. And the membrane that we're going to use, again, is a Cytoplast membrane. We prefer the one that has the textured surface. It's a TXT 200 singles. This membrane is very reasonable cost. I think comes out to about $35 or $40 per membrane. So very reasonable cost, which allows us to do this procedure at, again, a reasonable cost to the patient as well. We're going to contour the membrane to fit the site, as we're doing on this model. And then we're going to reconstitute our bone graft. This is a Mineralized bone graft in a sterile Dappen dish. I do add a little bit of tetracycline to my bone graft. Again, the site is not vascularized at this time when you put the bone graft in, so I've added a little bit of tetracycline. And there's some literature on using tetracycline. This is actually minocycline, which is a similar drug to tetracycline. Tetracycline is not available. Minocycline works as well. And you just want to add a little bit, just enough to give the bone graft a little tinge of yellow. We'll reconstitute that with sterile saline, and then we'll go ahead and pack that into our site, tuck our membrane into the tissue, between the bone and the tissue, put the bone graft in. after we've curetted and debrided the site thoroughly and irrigated it with sterile saline, we put the bone graft in, cover it with the membrane. And you do want the membrane to be about 3 millimeters beyond the crest of the bone. So you don't want to just go right to the crest. You want to go beyond the crest. You want to keep it about 1 millimeter from the adjacent teeth. This is, again, Dr. Barty's technique that he's published on. And then you close over with horizontal mattress or a cross mattress, as you can see in this case. What's going to happen is at about 1 week, you'll want to take out the sutures. So these sutures will come out at about a week. And then at 5 weeks, 4 to 5 weeks, you'll take out the membrane. Now what you'll see underneath is granulation tissue. You might see a few bone particles mixed in with that, but you typically see granulation tissue. If the procedure has been done properly, you'll see granulation tissue. It's not epithelium. It takes about another 6 weeks for that to epithelialize, but then you will not have disrupted the gingival architecture of the site, and you'll have keratinized tissue that grows over the top of it, which again gives you bone from this technique. You'll have bone, you'll have the volume of bone, the full volume of bone from the socket, as well as keratinized tissue. And I have a saying, the two things that I need to place an implant, I need adequate bone, and I need, or abundant bone and abundant soft tissue. And so with this technique, I'm not only gaining bone, I'm gaining soft tissue. So here's a clinical case. A tooth that has an abscess needs to be extracted. We go ahead and extract the tooth atraumatically, preserving as much bone as possible. We see that there's some cystic material there. We will remove that, curette the site, and we have most of the bony walls existing. We'll go ahead now and place our bone graft after curetting and irrigating the site with sterile saline. This is a Mineralized product again, mineralized corticocancellous material. We'll place our Cytoplast membrane over the top of it. And here I only used a figure-8 suture, but there was some change to gingival architecture by using this, but very slight. And at 1 week, we take out the sutures, and this is what we have now at 4 months when we go back in to place our implant. We have regenerated the entire socket. This is Olive. In Olive, you can see she's got some needs here. She's lost a bridge. Now, the problem with this case is that Olive had this bridge made 2 years previously. So she didn't feel like she got her money's worth from the bridge that was made here in the lower left segment. But the only option we could offer her were implants at this point because she did not want to wear a partial denture. So here is what her teeth look like. We went ahead and took those out, and you can see that we were able to get those out pretty atraumatically, preserving as much bone as possible. We placed our Cytoplast membranes over our bone graft. You can see on this premolar site, there was actually a defect in the bone around the tooth. A lot of times we'll see that, the sockets themselves are not complete. The bone is not complete, but in this case, there was a defect on the facial of the tooth. And you can see how just using this simple technique, we're going to be able to regenerate that. This is what the site looks like sutured, and here's an x-ray post-op. This is at 5 weeks. Remember, we took the sutures out at 1 week, but then we left the membranes in for 5 weeks, and then we pulled those membranes out. And typically, we're doing this without any anesthetic because they come out pretty easily. I don't have enough time in this webinar to go through every single step that we do, and there are some steps that are going to be left out, but the basic, the most important steps are being shown here. We take out the membranes, and we'll leave the site now for another 3 months to let that site heal up. We'll have granulation tissue here under where the membranes were, but the keratinized tissue will then grow in and epithelialize. We go back in at 4 months, and you can see how we've regenerated even that socket where we had that defect on the facial of the bone. And this is a molar site behind it. And we're able to place 3 implants here for a 3-unit splint. we were able to place the implants. We let those integrate for another 4 months, and then we go ahead and take our impressions and have our lab fabricate our abutments and our crowns. So a resolution to the situation where this patient had a bridge that failed, a failure of conventional dentistry, and I expect that this bridge now will last Olive pretty much for the rest of her life. She was actually in her 70s when she had this treatment done, and given the predictability of dental implants, I do believe this will last her the rest of her life. Here's Nate, a similar situation. We see that Nate has, except this is in the maxilla, Nate has some teeth that need to be removed. He had a bridge that failed, and he postponed treatment for a while, and you can see there's going to be a lot of defects in this bone here. The question is, because the sinus is so large here, the sinus is so pneumatized, are we going to need to do a sinus graft? And that was one of the things that we had to talk to Nate about, because we weren't sure where we're going to regenerate, where we were going to be able to regenerate all the bone we need here to place implants. So this is one of the things that we had to talk to Nate about. But we forged ahead and we extracted the teeth, and you can see the entire facial plate was missing on tooth number 5. But we go ahead and we actually used a similar technique here. We actually used what's called a dual layer technique. Again, something that was developed by Barry Barty. We place a collagen membrane over our graft, and on top of that we put the Cytoplast membrane, again, so we don't have to get primary closure. The posterior sites had good bony walls, so we didn't have to use collagen there. This is, again, called a dual layer technique. This is what it looked like at 1 week. Here it is at 5 weeks. We're going to take out the Cytoplast membranes. And 4 months after the graft, we're going to get a scan, because we want to know how much bone we've regenerated and do we need to do a sinus graft at this point. And as you can see from the scan here, the site of tooth number 2, we actually had adequate bone. The site of tooth number 4, we did regenerate the socket completely. And at the site of tooth number 5, where the entire facial plate was missing, we're actually, again, able to regenerate that entire socket enough so that we could place a 3.8 by 12 millimeter long implant. So we open the site and place our implants with cone beam technology. This becomes a very, very predictable procedure. We know exactly what we're doing, the sizes of the implants and the length of the implants before we go in and place them. And we're able to place our implants. Again, this is what we started with. This is what we had in that same site after the regeneration of the socket, using just a very simple Cytoplast and dual layer technique. This is the site now ready to be restored. At 4 months after we place the implants, we'll go in and take our impressions. And here we're using stock abutments, trying to help lower the cost of treatment for our patients. We use stock abutments and a PFM bridge, and that's the final bridge for Nate. So it's a situation where at the beginning we weren't sure we were going to be able to avoid a sinus graft, but in the end, through socket grafting, we were able to prevent the need for a sinus graft, and we're able to place our implants. This is a case where, this is Ashley. This is actually a case where I did not place the implant after the socket graft until 13 years later. This is Ashley at 12 years old. Ashley presented, she was out roller skating and fell and fractured a tooth. She had a compound fracture on tooth number 9 here. Actually, this x-ray is reversed. This is tooth number 9. And at the time, my best knowledge was to remove this tooth. I've since been told by endodontists that maybe they could have regenerated this tooth. I still think I did the right treatment here, because this tooth had a lot of mobility, and I didn't feel that this segment would fuse back together. So we removed the tooth, and placed a bone graft. And you can see here, this is actually the same site 13 years later. Ashley disappeared from my practice, and 13 years later she walks in and said, "Hey, Dr. Ferguson, I'm ready to have my implant placed." And she had been wearing a flipper all this time. So here's what she looked like. I looked at the site, and of course the question now is, do we have enough bone? It looks like it on this x-ray that there's some bone graft there, but I'm not sure about the volume. And the only way that I know of today, other than opening up the site to check the volume, is to do a cone beam scan. Here's what it looks like from the side view. You can see that there is a deficiency here. Now, the question is that deficiency in the soft tissue, or is that deficiency in the bone? And again, we go to our 3D imaging. This is what the 3D image showed, and this is from our Prexion unit. And I have a saying about my Prexion unit: when the image is clear, there's nothing to fear. Here you can see that actually over the 13-year period, we were able to preserve the entire socket. We had the entire volume, and we were able to now treatment plan and implant into that site. The material I used here was actually a material that is no longer available on the market. It's a material called Osteograft N700. At the time I placed a graft on her, she was 12 years old, I knew I wasn't going to be able to place an implant into that site right away. So I wanted to put a material that was going to last longer than Allograft would. And in this case, it was a dense HA material. Now, I can see there are a lot of particles here, and the question I have in my mind now is, am I going to be able to place an implant into that graft and have it integrate? And there's really only one way I know of making sure of that, and that's to do a histology on the bone. So we went ahead and treatment planned the case. And here it is, that this image here is an image from the Prexion scanner. And then the next image is from the VIP software, where we were able to treatment plan the case. That one's not running. So we were able to treatment plan and place the implant in virtual reality. And what we see here, though, is the day we went in to place the implant. Again, I'm not 100% sure at this point what's in there, what's in that site. But I opened it up and I saw that we had bleeding. It looked like bone. I could see some bone parts, some of the HA particles remaining. But we're not sure exactly what is in there, what percentage of native bone we have versus the original bone graft. So what I did in this case was I took a core of bone. And you can see it looks like it's got vascularity. You can see it's got some bleeding points there. I took a core of bone out of the site, and that made me feel pretty confident. I had to make a clinical decision as to what I'm going to do with this site. I went ahead and took a core of bone out. I used a trephine that was smaller than the implant that I was planning to place, and this is what the core looked like, and I sent it off for a histological report. Unfortunately, it takes about 3 months to get this histological report back, and this is what it looked like, but I didn't have this information at the time when I took the core and placed the implant. So it was a clinical decision. But based on this histology, we see that we had 57% vital bone. 57% of the core was bone, and of that 100% was vital. We had 24% marrow or fibrous tissue, which is pretty normal in bone, and then we had 19% non-bone, which are the HA particles. So we had about 19% HA particles, which was pretty good. I felt pretty confident after I got this report back that I had made the correct decision to go ahead and place that implant based on the fact that we had 57% of vital bone of the site. So today, if I was to do the same case on a 12-year-old, if I had to do a socket graft, I would use a material that was a combination of a resorbable material and HA, a dense HA. And to me, that is this material called Oristruct from Salvin. We use it, we mix it in with our bone grafts a lot when we want to extend the resorption time. And I think if if I had a 12-year-old, I would want to place the implant somewhere around 16 years old, so I'd want to hold off for about 4 years, and this would be a good material to use because it has that dense HA material in it. But going back to Ashley, we're able to place our implant, and here it is in a two-dimensional view, and here's a three-dimensional view. Immediately after placement, you can see we had 2 millimeters of bone facial to the implant, so I'd consider that a good placement. And after about 4 months of integration, we go ahead and uncover our implant. We developed a soft tissue through a custom anatomic temporary abutment and develop it further, adding material, and you can see this is what it looks like from the occlusal view. We did have to do a connective tissue graft here because of the defect that we saw on the initial photographs were not in the bone, but they were in the soft tissue. So we did a connective tissue graft to build up the facial tissue and get our tissue contour, and that's what our final crown looked like, to match the adjacent tooth number 8 shape and form. And this is what it looks like in her mouth from with her smile. So we're able to do a customized temporary abutment to mold the tissue, and then the final crown we used a zirconia abutment based on that form of tissue that we developed with the customized temporary abutment. Here's another case. This is Nora, and Nora is in her 40s. She's a little bit older than Ashley, but she came in with a fractured tooth. And in Nora's case, we took the tooth out, and I always try to take the tooth out before I do the scan because we'll get a much clearer image of how much facial bone there is. And you can see it looks like there's facial bone here, but keep in mind this is just a slice. This is a two-dimensional slice. And when we look at the 3D reconstruction, we can see that what we have here is a defect in the facial bone as well as a large incisive foramen. So we have to be very careful if we're going to place an implant. And a lot of times I like to place an implant in the aesthetic zone, the maxillary aesthetic zone, immediately with temporization. But in this case, I was not confident that I could get enough initial stability with my implant placement. So I did plan to place the implant and basically do a socket graft around it. And here it is in the virtual implant placement software, how we're able to visualize what it's going to look like. You can see that the defect in the facial plate there. So it's a situation where I want to place the implant, but I'm not necessarily going to load it immediately. So we go ahead and place our implant. And one of the things we're using in our practice now to judge whether we can load our implants, at what stage we can load our implant, is the Ostel unit. Ostel gives us a number. It's more of an objective measurement compared to a subjective measurement, and gives us a solid number that we can say, okay, based on this number, should I be doing a 1-stage, a 2-stage, or immediate loading on an implant? So in this case, I did not use the Ostel on this case, but now we just started incorporating this into our protocols. And this is what Nora looked like after we placed the implant. You can see we've got bone all the way around the implant, palatal placement, and then we grafted around it with bone, with our Mineralized bone graft material, and covered it with a Cytoplast membrane, and everything integrated. And after about 4 months, we went back, uncovered the implant, placed temporaries. Now in this situation, we had to do 2 teeth. We had to put a crown on tooth number 8 just to get them to match. And once we develop our soft tissue with our temporaries, we'll go ahead and take our final impressions, zirconia abutment, and 2 crowns. That matched pretty good in this case. And here is a 1-year follow-up on Nora's case. So pretty good result using implant placement, cone beam technology, and a little bit of socket grafting around the implant to develop, and then developing the soft tissue to match. So I'll finish up with this case. This is Rory. Now I don't always place implants at the time of extraction. I did on Nora and I did on Rory's case, but most of the time, probably 95% of the time, we're extracting teeth and doing socket grafts and going back later and placing the implants. But on Rory's case, I felt this tooth was unrestorable. He had a short root on the distal, and I felt that we could engage enough bone there, even though this was a molar site, to place an implant and, again, do a socket graft around the implant. So this is what it looked like after we took the tooth out atraumatically, preserving all the bony walls. We went ahead and placed our implant, packed bone around it, and in this case I did use the collagen, the dual layer. We placed a layer of collagen with covering that with Cytoplast, not getting primary closure, and this is what it looked like after everything was grafted. This is at 5 weeks. At 5 weeks, we'll go ahead and take out the membrane, the Cytoplast membrane, and you can see we have granulation tissue underneath. That, again, will epithelialize in about 6 weeks, but the site is now sealed and protected. It's now a sterile site, and we don't have to worry anymore about the graft getting infected. This is what it looked like after about 4 months. We uncover the site, and we take our final impression, and we do a screw retain. In this case, we did a screw retained restoration, again, that matched the form and contour of the adjacent teeth. And here he is with us in occlusion. So this is what we do on a regular basis. This is actually 6 months later at his recall appointment. We took an X-ray, regular bite ring X-rays. So to summarize, this is what we do in our practice on a regular basis, and socket grafting is basically the backbone of what we do. This is our list of speakers. This is actually our speakers from our comprehensive course. If anybody wants to learn more about these techniques or actually wants to do these techniques and learn how to do them properly, we welcome you to go to our website and check out our course, our comprehensive implant training course. We have a oral maxillofacial radiologist that teaches cone beam interpretation, as well as an expert on guided surgery, computer-guided surgery. Dr. Acker teaches prosthetics. We have Dr. Avi Shetrit, who teaches soft tissue. We have a prosthodontist, Dr. Ala Leopardi, who teaches advanced prosthetic techniques. And then also we have 8 days of live surgery where the participants actually get to do the treatment on patients at the University of Florida Clinic. It's actually held in Seminole, Florida, where they have a teaching center there. So again, I'd like to thank OsteoNews for allowing me to present this webinar. And there's my email address. If anybody wants to contact me, I'll be happy to elucidate any of the techniques I showed in this webinar. Thank you very much.